Hi, I'm Martin from EGA. I have a question concerning the connection between pharmacovigilance and counterfeiting. It was already touched a few times in the presentations that there can be an extent of the Falsified Medicines Directive, let's say, towards identification of biologicals and also traceability. And I was wondering if you would have an idea on in which way or and how much you would use this Falsified Medicines Directive for these pharmacovigilance purposes.
Do you have a specific person to whom you want to direct this question?
Well, everybody except for Suzette.
Maybe, shall I have a go just to get things going? I think a number of people have identified that there may be opportunities in the Falsified Medicines Directive which could facilitate traceability of biological medicinal products. The very preliminary discussions that I've been party to have often highlighted the differences of the objectives of the Falsified Medicines sort of barcoding type system compared to the identification of biologics that was underpinned in the pharmacovigilance legislation. But I think it's probably fair to say that we need to further explore this area, because I, for one, don't fully understand how the Falsified Medicines Directive is going to be implemented in that regard. I think that we're expecting something from the Commission relating to implementing measures on that barcoding or whatever it will be. But I think we should look and keep ourselves on the same page to make sure that if there are opportunities that we can grab them. So I think at this stage it's quite early to say. But I don't know if any of the colleagues from industry who have been following the falsified might have a comment on that.
I have to admit, I have not followed this in detail, but I would assume that the barcode really can be used at a pharmacy level to ensure that the records are up to date. And as I said, we live in an electronic world. I would hope that in future it is possible to link that very accurately with the patient records.
Perhaps just one comment. We had similar comments from colleagues from pharmaceutical industry previously, also in the context of the standardization activities. And just to mention that as part of the standards development, we had also GS1, the organization participating who is responsible for developing barcodes. And of course, they are also very much focused on the identification perspective from a counterfeit issues perspective as well. And as I said, from a standards development perspective and IDMP, you will see that the barcode can be also carried as part of the identification. Now, how it will be applied from a falsified medicines directive perspective or counterfeit perspective, we don't know yet, but it has been certainly brought to our attention that it is important that we should keep these aspects in mind, and in order to avoid to create additional identifiers which would prevent us to combine pharmacovigilance with the other aspects as well.
Thank you, and I'm sorry for the bit of label question. But so for pharmacovigilance purposes, it would only be the barcode or the identification which would be important.
Well, as I said, we have not yet addressed the actual implementation of the IDMP standards in the future for the pharmacovigilance perspective. But what I wanted to mention as part of my introduction is really that the standard has covered really all types of identification, and then we have to engage with our stakeholders to which level we want to apply the identification to support our business processes and the different business needs. Sorry, yes, please.
Dave Lewis from FPS Sabine. One comment and one question come challenge, if I may. Comment first, Sabina Strauss. The increased reporting of batch numbers bears a sinister correlation with FDA requests and requirements published in 2007, which, if I remember rightly, increase the visibility and external packaging notification of batch numbers and lot numbers. And if industry as a whole responded by doing that for the US, it's realistic to guess that they might have done that globally. So there might be a correlate to try and check there for you. The challenge, the question that I'd like to throw in is really related to transparency and traceability. I guess one of the biggest challenges I face is having a massive data set called Eurovigilance, which I don't have access to. So what I'm going to suggest is really hugely controversial. I haven't discussed with FPA colleagues, so brace yourselves, folks. Why can't industry sponsor an application, I'll call it, whereby we could club together and get the budget that you don't have to make the E2B data available through a portal to industry? Then we can receive the cases that currently we don't get. We can have a degree of transparency, traceability. We can augment follow-up. We can see the cases that currently are invisible. I would say potentially if we could club together even just the big pharma to get a portal built, to get a download system, we then end up with what was called for on the 1st of January 1995, which was electronic data transfer for pharmacovigilance. So currently we're sending a lot of reports into Eurovigilance. We have the MHRA portal and other authorities, national level, who will send us cases, but we have no uniform large-scale transfer, two-way interchange. Comments welcome.
Okay, so if I may give you first the EMA perspective, and then maybe my other colleagues would like to respond to that. No, I think, Dave, it's important to understand that we are moving into that direction, and you will see also with the provisions in the new pharmacovigilance legislation that the goal, of course, is to provide access to marketing authorization holders to Eurovigilance. Now, you will also see as part of the provisions before we can do that, there is also the expectation that the system overall will be strengthened, that it will be adapted from a technical point of view to meet these new requirements. And in this context, we are working now in a period of transition where we will make these technical enhancements, where we will then have a subsequent audit, an independent audit, which will look into the functionalities of Eurovigilance. And then following the hopefully positive outcome of this audit, we will have the possibility then to open the system also to marketing authorization holders, and then also to achieve the simplification of the adverse reaction rules or reporting routes that has been mentioned by Peter in his introduction as well. So it's not that we have not thought about it, but it is work in progress, and we're working towards that goal. Yes, please.
Sorry, I pressed the wrong button. It's too close to lunchtime. It's really in response to what Dave suggested, and I guess my first thought was flying pigs. And then my second thought was, I can completely understand the proposal, but I suspect one also has to take into account how that kind of initiative might be viewed externally, and the need to which, you know, EMA have to be at least perceived to sort of keep a distance from us nasty old industry people. So I guess, whilst entirely honourable, Dave, I just don't think it's going to be practical.
Well, perhaps just if I may, if I may make one remark, I think it is practical. We have a legal basis to work towards that direction, and you will also see from the GVP modules on signal detection and signal management that it is important that we will have access to the same source of data that we are using, and that you will have also the possibility to look and assess this data as well. So I'm positive that this will be achieved.
I'm also confident we'll get there, although it's part of the marathon rather than the sprint part that I presented earlier. Just a couple of comments, and thank you for the innovative ideas. And I think areas like the Innovative Medicines Initiative have shown that if we put the right structures in place and we have clarity of roles and responsibilities, public parties and private parties can work together. I think the key issue here is that the income of the European Medicines Agency has got a very clear legal basis. It's the fees regulation. We have a commitment from the European Commission to put forward a proposal for changes to the fees regulation by the end of the year. We would hope that then within a year from that proposal being adopted by the Commission, that we would be able to start collecting new fees that will then allow the investment that's necessary for a much more sophisticated and selective access type system for eutrovigilance. Maybe just one other comment, because for us also the holy grail, if you like, is the Article 57 lists of medicinal products and the substances they contain. Once we have high quality data submitted by the industry that's been validated, that allows us to know all of the products authorized on the European market and the substances they contain, it then gives us the basis to give selective access to the marketing authorization holders for specific products and specific substances. So we're all moving in that direction, but it's going to take a couple of years to get there. And thank you, Dave, for the innovative idea. I think for the short to medium term, we're going to rely on our Commission colleagues to try and solve this one for us. So.
Okay, thank you. Are there any final questions? Yes, please.
Okay. I would like to go back to the topics of identification and traceability, which was the subject of this session. And also what I would like to say is really pleased to hear that there is consensus across both sides of the industry with regard to the legal requirement to identify a product by the brand name and the batch number for suspected adverse drug reaction report. So, and also really interesting to hear about the experience from the Medicine Evaluation Board in the Netherlands with regard to facilitating using batch numbers for a spontaneous report for adverse drug reaction. And so the question is addressed to the representative from the national competent authorities, is what are the measures would be put to ensure compliance with this reporting requirement about the batch number across all member states, and also how to, maybe through education or helping especially healthcare professionals in the kind of complying with the legal requirement. Thank you.
Well, thank you very much. I can, of course, and that's one of the difficulties that EMA is also facing, only talk concerning my own responsibilities in the member states. It's, of course, up to the other member states how they are going to implement and how they are going to track and trace. What we will do is we will start certainly a campaign. We have in the Netherlands already the legal obligation for a healthcare professional to report serious adverse events. And we will start together with our national center an awareness campaign. We were very happy seeing that patients are very willing to report. Probably they have a very big interest in reporting, and as soon as they are convinced about the possibilities and the need and the opportunities, we will like to try and make batch numbers better available to them in order to help them. So we have several initiatives ongoing. We haven't had yet the chance to think about how to monitor the compliance later on, or monitor is not that difficult, but how to ensure compliance. That might be a different issue, and we are discussing that with our inspectorate. But for other member states, I know there are a lot of initiatives, but how they will proceed, I'm not sure.
And that perhaps, as Suzette has mentioned, we can follow up later on this year to see how this has been implemented or approached at member states level, and then also come back to you and show you the experience from the implementation in the different countries. I think there was one last question here.
Richard Price, European Association of Hospital Pharmacists. More of a comment than a question. There seems to be a small consensus that the falsified medicines unique identification system should not be constructed in isolation to pharmacovigilance and the benefits that it might bring. That's something our organisation has strongly felt, and we've recently written to the Commission on this, calling, for example, for the system to enable barcoding of the single dose administered in hospitals. And the comment I wanted to make was the delegated act or to construct the falsified medicines unique identifier is very much in a development stage, and I think other organisations could helpfully make representations to the Commission on that point about pharmacovigilance.
Well, thank you very much indeed. That's a very useful perspective. So now we've come to the end of the morning's agenda. I would like to thank Sabine Brosch once again for bringing together an excellent speaker panel that have really given us the different perspectives very concisely. It's excellent to see the evidence base being brought together and established, and that will continue. But it's also good to hear some innovative thinking, and that's what we've always got to do, to think laterally, but to think forward and think innovatively. So I'm sure we'll be coming back. The topic has already been proposed of biologics in the governance structure for a reflection paper. That will be coming forward in the autumn. And as you heard from Priya, there's a possibility, possibly down the line, of a specific module of good vigilance practice. So it's all to play for. Keep thinking and keep talking.